started with chapter 1, which is emergency medical care systems, research, and public health. So this chapter just basically covers the background information of how EMS started, how we keep up to date with new protocol, how we keep up with medicine and how it started off. So EMS developed from days when the funeral home was the ambulance provider. So basically there was no care in someone's home. If they died, the funeral home would basically just pick them up, or if they were able to get themselves to the hospital, that's when medical care would actually begin. And as far as patient care, we learned that specifically from previous wars, and how soldiers were actually benefiting for treatment in the field prior to transport to a hospital. Accidental death and disability, the neglected disease of modern society in 1966, the National Academy of Sciences, National Research Council published the report, also known as the White Paper, which detailed the number of deaths and injuries related to traffic crashes in the United States. So they basically took the research from traffic accidents and how patients were responding to treatment in the field, and we also started getting more research on the deficiencies in the delivery of pre-hospital care in the United States, which was able to make some recommendations on how to change the ambulance systems, trainings requirement, provisions needed to be made through personnel, the actual care itself. So it's all just kind of been like a learning experience over time, which is what medicine is. Certifications. So National Registry is in place to make sure each student nationally is able to provide the same standard of care. However, just because everyone is certified to do the same things, all states may not all practice the same skills. This is why you must obtain a state license after being nationally certified. Your actual clinical skills will be based upon your local state protocols. All right, so your levels of provider care in emergency services, each as a specific role and responsibility. So your paramedic is going to be your highest level of care, and your EMR is going to be your most basic level of care. So your EMRs, your classes are normally about a week long, and they can do almost everything that an EMT can do besides providing airways. So once you're able to provide those airways, you move on to, as an EMT, you're able to provide those airways. An AEMT can then, on top of all the things that an EMT can do, they can go ahead and also start IVs and push some medications. They can't push as many medications as a paramedic or any of the cardio drugs, but they are able to read some rhythms on the monitor. They are able to push some drugs, but your most invasive treatments, like all of your cardiac treatments, your cardiac medications, all of your medications, I should say, are able to be done by your paramedic. Your invasive airways, intubations, those type of things are all done by your paramedic. So anything that basically says any type of advanced assessment or advanced treatment, that's probably going to be your paramedic that does those. But your EMT is able to do your basic level of care. All right. Roles and responsibilities of the EMT, just to go in depth more of what we just talked about. Maintain vehicle and equipment maintenance and readiness, ensure safety of the EMS crew, the patient, and bystanders at the scene. Operate the emergency vehicle. They are able to assess patients, provide emergency care. They can safely lift and move the patient. They can prepare oral and written reports, safely transport the patient. They transfer patient care, normally to a higher level, equal or higher level of care. And they perform record keeping and data collection, serve as the patient's advocate, provide emotional support to the patient's relatives and others on the scene, integrate the EMS service with other emergency and non-emergency services, resolve the emergency incident, maintain medical and legal standards, provide administrative support, enhance professional development, develop and maintain community relations. So those aren't, you don't need to remember all of those specifically, but those are just a just for you to start understanding the level of care that a EMT can provide. All right, so how we talked about your levels of care start off with your EMR, then on to your EMT, your AEMT, and then your paramedic. Um, so above all of that, we are all working under the license of a medical director, which is basically a doctor that has gone through schooling, has practiced medicine, and now has decided to create protocols um, and allow us to work under his license as the EMS professionals. So, your medical director makes medical policies, procedures, and practices that are available to EMS providers either offline or online. So, don't be confused with when we say online. Most people like to think of it has to be, I have to physically get on the internet or check the computer, to get these orders. Online basically means you are talking to this person, you are talking to this medical director, um, and giving orders. So, this can either be by radio, by phone, and then your offline orders are your standing protocols, are your protocols that are already written. This doctor has already done research on this and established that this is a good way to proceed with this care or this treatment plan for this specific problem, um, and has written this down. So this is a specific protocol that everybody must follow. If you come into this problem, this is how you should respond to this. um like if you get an asthma patient, there's a protocol for asthma. So you know you should be placing this patient on oxygen. You should be listening to lung sounds, checking if this person's wheezing. They should be put on a nebulizer treatment if they don't have an inhaler themselves. And then it can go on. So that would be your basic level of care. But if it went on into your paramedic level of care, we can start giving steroids or epinephrine or any some other types of drugs to try to help with that broncho spasm. But those are all protocols that are written in place, so they are offline. They're already established. Things that aren't established. So if you go anything beyond that, say you've done everything on that written protocol already, and you see that this patient isn't getting better, or they defer off of that protocol, and now you're coming up with a new problem that isn't written in stone already. This one you would call and get online orders. Um, Call up the doctor and he'd tell you what to do over the phone, and that would be considered your online orders. So, quality improvement is a system of internal and external reviews and audits of the EMS system. They're not meant to penalize anyone, but it is an evaluation of the EMS system geared toward improving it. So, they're not out to, if quality improvement was to go around and pull one of your patient care reports, they're not doing it to specifically target you. They're more so looking at, okay, this person, they had a seizure patient. They didn't check the CBG on it. So then they'd go pull, this other patient, like say they pulled another medic. They're going to pull so many calls, so many seizure calls. Not specifically yours, but they're just going to pull so many seizure calls in this specific amount of time and kind of use that as a research and database for, okay, like I had this many seizure patients, only this many paramedics or this many EMTs check the blood glucose on this patient. So what can we do to increase the amount of times that we are checking these CBGs on these patients? What can we do to educate our EMS staff? So it's not necessarily geared, if your ticket is pulled or audited, it's not necessarily towards you. It's more so to better the company as a whole. All right, and that is it for chapter 1. So chapter 2, workforce safety and wellness of the EMT. So this one just kind of basically goes into learning how to recognize your stresses, learning how to not only recognize but not necessarily treat, but acknowledge, and figure out what you can do better to avoid having stressful situations at work. Also learning your resources. Diseases are caused by pathogens, microscopic organisms that are all around us and living sometimes in the patient you're treating. So you should be protecting yourself. Common pathogens are bacteria, viruses, helminths, protozoas, and fungi. Bacteria are microscopic, single-celled organisms that reproduce on their own or within a host. So your common ones are your sinus and ear infections, bacterial pneumonia, strep throat, tuberculosis, UTIs, those type of things. So when you have some type of bacterial infection, this is what your antibiotics are used for. Then you have viruses that cannot grow on their own. They need a host to reproduce. The main thing to know here is that antibiotics will not work on a virus. So mainly because your viruses need an antiviral, not an antibiotic. They'll need an antiviral, and your virus needs a host. So the virus basically attacks the person. They bind to the host cell, which you would be the host. Uh, and in order, they survive off of like your blood supply. So in order to kill off that virus, it would normally hurt the host itself. So that's why antivirals, aren't as common as antibiotics, but your antibiotics are specifically for bacterial infections. Your common viruses are colds and flus. Others include HIV, Hep A, B, and C, chickenpox, viral pneumonia. Fungi are plant like microorganisms that typically do not cause infection in a person with a normally functioning immune system. They could cause diseases in a person with a compromised immune system like HIV or leukemia. Protozoa are single celled organisms that are typically found in the soil and are able to move. Mosquitoes carry protozoa that can cause malaria. And helminths are parasitic worms. These are your roundworms, your tapeworms that cause infection. They usually introduced to the body via the ingestion of tainted food. All right, immunizations. So hepatitis, this is just a list of the normal immunizations and when you should be taking them. So the main ones to know here is that your influenza your influenza, which is also called your flu, um, vaccine, and your PPD tuberculosis test should be done annually. So Hep B can be contracted through blood or other bodily fluids. A person who is a chronic carrier may not know because they may not have signs and symptoms. It's important to get this vaccine. Hep C, because the most common form of blood-borne infection in the U.S., transmission via mucous membranes is rare. So in the field, how do you think we can contract this? Um, your most common way is introduction via a dirty needle stick. And there is also good to know that there's no vaccination for Hep C, so you should be really, really careful when you're working with an infected patient and dealing with needles or transferring bodily fluids. This is why we use sharps containers, standard precautions, PPE. Very important to take standard precautions when dealing with bodily fluids, especially blood. Tuberculosis is caused by a pathogen in the lungs and can be spread through droplets or sputum from a patient coughing. These patients, you should be wearing eye protection for, gloves, an N95 mask. I think that's it for immunizations. All right, U.S. Department of Occupational Safety and Health Administration, also known as OSHA, guidelines require EMS to take precautions against disease transmission by blood and other body fluids. That's why we wear what we wear. Gloves, masks, eye protection, and proper hand washing techniques should be used. So, your standard precautions is a term used to describe protecting yourself from the disease transmission through exposure to blood and other bodily fluids. It was formerly referred to as body substance isolation. So if you hear somebody say BSI, it's the same thing as your standard precautions. First line of protection from spreading disease is hand washing. That is the most important thing to remember from that slide. All right, so your 5 emotional stages. It's good to recognize these. They're not really much of anything you can really do about them, I should say. Like if they're commonly called the 5 stages of grief as well. I mean, if someone's dying, there's, and you're helping a family cope or the patient cope with this, you should probably recognize which stages they're in just so you can kind of help them cope through it. So the not me stage, if you hear a patient going on about not me, this can't be me, this isn't true, this is a denial stage. Um, Anger is more so the why me. They've accepted that it's them, but they don't understand why. Why are they being punished? Why are they going through this? Bargaining is normally your patient that they may get this terminal diagnosis, and they're like, okay, well, before I do this, like, let me go on this trip first, or let me go do this first before it happens. um, the depression stage is when the reality kind of sets in, and a patient may become distant or worried about who and what they will leave behind. Um, they start to recognize and say things like, "Okay, but I haven't done this yet, or I haven't had a chance to live my life yet. I haven't had a chance to do this. I haven't had a chance to make this person proud or this yet." That's more so of your depression stage. And then your acceptance stage is normally the last phase, is where they accept what's going on. um, these are normally your patients that tell you, I'm okay with dying, I'm not afraid, I'm not scared, you know uh, and they're kind of moving on to that transitional state. All right, handling grieving patients. So maintain a patient's dignity at all times. Always show respect and communicate well. Make sure you're making good eye contact with these patients. You're using good gestures. You're not using like a stern voice with them, or you're being impatient. Um, these people are going through, this is their last days, so you should be very conscious of what you're saying, what you're doing, um, and how you're reacting to them. Do not give false assurances to this patient, like it will be okay. It's not going to be okay. They've accepted this. They know they're not going to be okay. Um, just kind of follow their lead on which stage of grief they're in, I should say, and kind of try to help them cope with that. Don't take anger personally. This is a big one, because sometimes they get frustrated and they're just mad with the world. They're not taking it towards you. Um, they're literally probably just mad with the world. So don't take any of this personally. This person is not trying to attack you. You didn't do anything wrong. Um, just try to, once again, help them cope through it. All right, types of stress reactions. So there are acute stress reactions that result from exposure to high stress situations. Um, Signs and symptoms are normally nausea, elevated heart rate, sweating. This typically occurs immediately or shortly after the incident. Then you also have your delayed stress reactions. So it may be days, months, or even years before symptoms are present. PTSD is a typical delayed stress reaction. So normally people have insomnia, flashbacks, nightmares. Um, Another one is cumulative stress reaction, the result of constant exposure to stressful situations over time. Burnout is a term used when someone is in a state of exhaustion and irritability. So if you're thinking about putting yourself in any of these situations and you're trying to figure out, okay, like, am I close to burnout, or am I just getting exhausted? Like, am I just having one bad day, or am I on the verge of getting burnt out? Definitely take the time, evaluate yourself. Ask people around you, because sometimes you don't realize it yourself. Ask those around you who are normally, your partner at work, your spouse, or your family members at home that are normally around you. See if your attitudes change or your habits have changed, if they've noticed anything different about you. But if you do notice anything, there are ways to manage them. So you can do a healthy diet, you can exercise. um, Always avoid self-medication. So don't turn to drugs or alcohol if you're feeling down or depressed, and now you start drinking every day, or you're turning to some type of other drugs. um, get yourself if you feel like it's that bad, get yourself evaluated. There's you know depression medications, anxiety medication. There's medicines out there. That's what these doctors are for. Just don't try to do it yourself. Never try to manage any of this on your own. Professional help is always available. So we have CISD, which is Critical Incident Stress Debriefing. It is a team of peer counselors and mental health professionals that assist emergency service personnel after a critical incident. It usually happens with 24 or 72 between 24 and 72 hours after the incident, and it helps the medic through the experience, and they can refer you to someone else if you need. All right, so that is it for chapter 2. Chapter 3 is medical, legal, and ethical issues. So this chapter is basically how not to go to jail. All right, so your scope of practice is defined as the actions and care that EMTs are legally allowed to perform by the state in which they work. So your standard of care is defined as the care expected to be provided by an EMT with similar training when managing a patient in a similar situation. So the standard of care is what's expected of you, and any other EMT around you. So all EMTs should have this standard of care. This is what they should be doing, right? And then your scope of practice is what you're actually legally allowed to perform, and that varies by state. So remember, your national registry would be kind of like your standard of care, what you can do as an EMT, what's expected of you as an EMT. And then your state standards would be more of your scope of practice, which you're legally allowed to do, because each state is different. What you're allowed to do in Louisiana might not be the same thing as what you're allowed to do in Texas or Mississippi or Arkansas or wherever. So it's always good to follow your local protocols. So going back to that DNR as well, you want to make sure the person that signed that DNR is the only person that can revoke it or change their mind on it, unless they have a power of attorney with them. So if they have a power of attorney, that person can go over. So if this person has like dementia or Alzheimer's and there's going to be a point where they're not lucid, that's where that power of attorney would step in and basically make those decisions for them. Anybody else besides that is not able to, renege that DNR. Um, Also, with that being said, a DNR has to be present in order for it to be followed. So if I'm doing compressions on this person and the family member cannot find a DNR, but they know that this person would not want compressions done and they're telling me to stop because they know that the person has a DNR, I cannot stop until that DNR is legally, like, it's in my hand and I see that it is signed and not expired. It's signed by the person, the patient and the physician, and not expired. Other than that, I cannot just stop off of someone's word. And then there's also, on the other hand, that the person has the DNR and they're like, oh, well, I don't want you, I want you to save them. They wouldn't want this. They would want you to save them. No, that DNR is in front of me and it is signed. I have to go off of this patient's wishes. So now that we know those, let's get into our types of consent. So your consent is basically just permission. Your informed consent is before emergency care is rendered, the patient must be informed of the care being provided and the associated risk and consequences. So any of these other following types of consent can easily turn to informed consent once you start explaining to them what's going on. So express consent. If I was to walk up to this patient, this is when the patient, who must have the capacity to make rational decisions and be of legal age, is informed of the emergency care needed and the understanding gives confirmation. So if I was to walk up to this patient and be like, hey, is it okay if I go ahead and get this blood pressure on you? I asked them, was it okay for me to do it? They said yes. They expressed to me that they would like me to go ahead with this treatment. So that's expressed consent. Now, if I was to keep on going and be like, okay, like I feel like you may be having a heart attack. Is it okay if I go ahead and I put this 12 lead on you to go ahead and take a quick little picture of your heart, make sure that you're not having a heart attack, and see if I see any changes or anything wrong with your heart? That would be informed consent, because now I'm informing them of what may be going on with them, why I'm doing the treatment that I'm doing. Implied consent is the emergency doctrine, occurs when you assume the patient would consent to the emergency care if they could. This is for your unresponsive patients or patients unable to make a rational decision at the time. So if a person overdosed and is unresponsive right now, I would take this as implied consent, because it's implied that this person would want me to save their life. It isn't, I don't think they intentionally overdosed on this drug, um, and that they would want to live. So it is implied that they would want me to treat them. Uh, Minor's consent is a consent to treat a minor must be obtained from a parent, legal guardian, or other person who has been granted limited rights of decision making. So teachers, step parents, or a babysitter at the time, whoever is in charge of this child at the time of this accident, I can get minor's consent from them. If no responsible party is present, implied consent is used. Involuntary consent. This is when you are dealing with a patient who is mentally incompetent or a patient who is in custody of law enforcement or incarcerated. So, knowing the different types of consent is important, but also knowing who can refuse care is also is a big thing to know. So the patient must have the capacity to make the decisions um, for them to refuse care. So let's say a patient that fell down some stairs. An older lady fell down some stairs. Um, we get there. She just wants some help up off the ground. She doesn't want to go to the hospital. She's refusing care, right? She just needed help. As long as she is able to tell me her name, what day of the week it is, um, who's the president right now, what month are we in, just general questions that show that she's competent enough to make rational decisions, she's able to sign that refusal. She is of legal age and she is in sound mind that she's able to sign this refusal. So this slide just lists the different types of consent again. Um, I also want you to just be aware of when you're getting a refusal on somebody, make sure you are covering yourself legally and you're making sure that this patient is fully informed of the risk of not going to the hospital, the risk of whatever condition they may be going through. If you have to bring up death, telling them that, hey, if you don't get this treatment, um, there's a possibility of you dying. You can die from this. Like, if you need to bring that up to emphasize the importance of them going to the hospital, by all means do it. But make sure that they are fully aware, that they understand that by signing a refusal, you are not, once you leave off of that scene and they sign this refusal, you are not held legally obligated. You are not legally obligated to, you're not responsible for anything that happens once you leave that scene. So if they die once you leave, that's out of your hands. You inform them of what was going on, the severity of their condition, that they should go to the hospital. You asked them more than once to go to the hospital, now that they can sign this document saying that you informed them and that they still don't want to go. By all means, they can still call you back. Let them know. That's normally how I tell them, like, hey, you can always call me back. If something changes and you change your mind, you want to go to the hospital, call me back. Somebody will be back to pick you up. This is not saying that you can't call us once we leave. This is just saying that once I do leave, if something were to happen, I'm not responsible for it. So just make sure you're educating your patient. So now let's get into torts. So, negligence is a deviation from your standard of care. Negligence is basically saying that you had a duty to act to this patient and either you chose not to or something you did and the patient suffered some type of harm from you not doing your duty to act, not doing what was expected of you. So simple negligence is when an EMT fails to perform care or when a mistake is made in the treatment. Gross negligence is willful, wanton, or extremely reckless patient care for beyond being negligent or careless, or the EMT causing intentional harm to a patient. And then you get into assault and battery. So, assault is a willful threat to inflict harm on a patient, and battery is the physical touching of a patient unlawfully without their consent. All right, so your duty to act is when you are on duty, you are legally obligated to provide care to a patient, whether or not you think they need an ambulance. The Good Samaritan laws protect the person who is not being paid for aiding in an emergency situation from liability, so as long as their actions do not constitute gross negligence. But just know that your duty to act goes so far. So you have a duty to act when, so say you're off duty. You're off duty, you're driving home from work, and you're in uniform, you're driving home from work and there's an accident on the side of the road. You can either keep driving and do nothing about it. You can call for help and keep driving, or you can get out and help the person. However, once you get out and help this person, that person is now under your care. So that means you are stuck with this person until someone of equal or higher level care shows up. So if you stop to treat help this person who is in a car accident and a fire department shows up, but you're like, oh, I gotta go pick my kid up from daycare. I have to go to this place. Like, I need to go. Like, here, y'all can have this patient. I'm so glad y'all here. Like, here, y'all can take them. No, that can't work like that because they have to be, as an EMT, you cannot hand off care to an EMR, a first responder, anybody that's not an EMT level or higher. So you can do an EMT, a paramedic, a nurse, a doctor, any of those things, but it can't be anything less. So no EMR, no fire department, no police department, anything like that. Negligence is the act of deviation from an accepted standard of care through carelessness, like we just talked about, which basically means something happened to this patient and it was your responsibility to take care of them, and then something you did or didn't do resulted in this patient being harmed. So that would be negligence. Abandonment is when a provider stops treatment without transferring care to a provider of equal or higher level of care. So just like we talked about your duty to act and how you would stop to help this person on the side of the road, if you were to hand this person off to a fire department or someone of lesser level of care than you, that would be considered abandonment. All right, so HIPAA is your Health Insurance Portability and Accountability Act. This deals with confidentiality. So this is the info you obtain while getting a patient history or physical assessment or while treating the patient, and it must remain confidential. You cannot speak to your buddies, your family, the press, etc. about specifics. This includes injuries, unusual behavior, or physical findings, specific illnesses, or diseases. Releasing confidential information requires a written release from the patient or legal guardian. So you're probably wondering who can I release information to? Because that's quite a lengthy list of people that you can't say anything to. So who can I actually release patient information to? So another healthcare provider who continues the care of this patient. So no, I can't call my best friend that's a paramedic and be like, hey, this such and such happened with this patient today. Like, you should have heard about this wild and crazy call I had. No. But if you are talking to the nurse that, say you drop this patient off at a hospital and the nurse that actually took over the care calls and asks you like, hey, how was this patient before you got him? Or, like he's doing better now or such and such, whatever. that would be okay because you're speaking with someone who also was responsible for care for this patient. You can also talk to Child Protective Services or any official public health or governmental agency um, that suspects some type of crime or child abuse or anything like that, that they need this information legally. You are able to tell them. That includes police as well. Um, or if for any reason you get subpoenaed to court, then you can release whatever information. Like if they ask you something in court about this case, clearly you can answer those questions, but you must be subpoenaed to court for it. All right, and that just goes over basically the stuff I just said.